clicker. As Mark was mentioning, Deidre has helped us with a lot of our stuff here. Obviously, she spoke last year about a lot of this, and I think the importance of being able to do some of this stuff or go back over it. It's one of those things, kind of like we start talking about heat illness and the things that we continue to do in our summer event. Going back through it, even though a lot of times the concussion side of things is, it's concussion. We do our job. We do the things that we normally do. Sometimes gets lost in the weeds, especially with the changes. And some of our medical direction sometimes changes of what their thoughts are or what's going on. My biggest thing for you guys is they are running a phenomenal clinic at Houston Methodist. What her and Dr. Padel have done, not only for us when I was working in Houston, but also for some of our schools here. And I know several of you guys have actually utilized them for some of your concussion issues. And I say issues as being those that they need a little bit more help. They need some more issues. I know with the Texans, remind me the actual name of the telemedicine grant. Okay, the Texans telemedicine grant, that has enabled and allowed us to be able to get some of our rural schools some help that they would never actually have been able to get. And I'm sure she will talk about that a little bit, but I just want to, this is what she brings up and what they're able to do is so important, and it's so awesome that they're able to help us in San Antonio just being in Houston. So thank you.
Thank you for the kind words, but I got to say I'm a little bummed because I thought I wanted to continue the roast up here, but I really got nothing. I can give him a hard time. Oh, that's true, Mark. But thank you so much to Mark and Sean for always putting on an excellent program, and thank you to Trinity and Methodist and Sports Medicine Associates. We really appreciate your time. And while a lot of it is repeated, because really we won't have another conference, a concussion center conference, for a couple more years, I think there has been some confusion with some of this that they've changed. So what are we going to talk about today, besides that I have no disclosures, except I do play the lottery, so fingers crossed on that. I did use that last year, so I went ahead and took it out. For our educational objectives, so we're just going to talk about the changes to the SCAT-6. We're going to talk about the SCOT-6, and also exercise as treatment and when they need more advanced care. Now, I do talk with my hands a lot, so sorry if I let the microphone stray. Also, just like our Dr. Rush, I want to make it interactive. So if you have questions as we go along, please feel free to ask. All right, so the SCAT and SCOT are 13 and up, and then you have the child, which is 8 to 12, and then, of course, the concussion recognition tool. That's really more for the lay person, your coaches, your student athletic trainers. It's pretty basic, but at least it kind of gets a start on the paperwork. So just a little bit of a history with the concussion sports group, led by sports concussion researchers and experts and clinicians. The first one was in 2001 in Vienna. 2004 was in Prague, and then that's when they came up with the first SCAT. They actually called it the SCAT-2, published in the following year, 2005. Then in Zurich, we see in 2008 the SCAT-3, and then that's where they came up with the child version of the SCAT. 16, we go to the SCAT-5. 2020 was when they were supposed to meet, because it's usually every 4 years, but we know why that was rescheduled. And then finally, 2022 was in Amsterdam, where they came up with version 6 and also added on the SCOT. So just a little bit of a timeline, or kind of how it works. It's actually pretty interesting. They do a lot of work to get to where the final outcome and where they are. So they started prepping in 2018. 2019, they had to address the pandemic and push things back. And then October 22 is when they actually met. And there's a lot that goes into that. People are asking questions, there's comments, everything is presented. It has to have an 80% agreement so that they can move on with what they want to present. And then finally, in June of 2023 is when it was actually released. So what goes into this consensus statement? There's actually 10 systematic reviews, and I don't want to read to y'all, so I'll just pop them up there. But these are the 10 systematic reviews that go into that. And it's over 55,000 articles that they've screened over these 10 systematic reviews. And so, of course, easy to find, you just Google it. But I did want to point out there is a YouTube video with Dr. Ruben Eshamendi, who was the lead person on coming up with the SCAT-6 and just kind of their thought process behind it. Also, I like to point out there are actually 2 separate PDFs. So for both the SCAT and the SCOTE, you have your actual page that you're going to record everything, but then there's a second separate PDF with the actual instructions, because not everything is spelled out on that documentation sheet that you have. And, while I do this every day, I know all of you don't. And so I just think it's important to, be able to refresh yourself, when you are having to give it. And the first part of the SCAT is what we would refer to as our sideline assessment. So it's actually called the immediate assessment neuroscreen. So it's the same as we saw before in the SCAT-5. Does have the red flags like it did before, and I went ahead and put a comparison up here so you could see what the difference was between the 5 and 6. So they added a couple more things. Visible deformity of the skull. I think that's, pretty apparent that would be a red flag, but they went ahead and added that on there. Observable signs, they added a few more things to this as well, just for, better documentation purposes. I know that you are already looking for these things. Then we have the Glasgow Coma Scale. And again, it's got the 3 rows there so that you can do serial testing if needed. Chances are you're probably only going to need to do this one time, but there are the rows if you need to do more. 15 points possible on that one. On the cervical spine assessment, same thing, not much added to it, just noting, tenderness till palpation, and then they just highlighted that spinal precautions were taken. Now, on the coordination, step 4, coordination and ocular motor screen, this was previously under the office or off-field part of the SCAT-5. And they did add a couple things to this as well. And the extraocular eye movement that they're talking about is the H and X pattern. So basically, you're having them, just like if you were doing smooth pursuits, you would have them hold their head still and do that nice and slow H pattern and then the X pattern, but you want to make sure you go slow and really take it out to the side so their eyes have to follow to the extreme. While we're doing that, it is testing the 6 cardinal positions of gaze. It's testing cranial nerves 3, 4, and 6 while we're at it. Maddox questions, no difference there. And then I do like to point out, there's no symptom assessment for the first part of the SCAT. So this is the one that you're doing on the field. So in my mind, that's important that we get the symptoms right off the bat, because really we don't see this symptom checklist until you get to the second part of the SCAT, which is the off-field assessment. And let's be practical. A lot of times it is not, well, I don't want to say a lot, probably most of the time, that is not going to happen. You're at practice, you're at a game, maybe you work by yourself, or you need both of you at practice or the sideline, you're not going to be able to take the athlete inside to a distraction-free environment to do the second part. So I highly recommend that you have a symptom sheet so that you can have that for documentation when they do get injured right off the bat. All right, so sideline assessment, what we don't see on there, which is important in my mind, is cranial nerve exam. And we've already knocked out nerves 3, 4, and 6 by doing the extraocular eye movement, the H and X pattern. But these other ones are not going to take you long. And we should be doing Pearl anyway, checking, reaction, pupil reaction, and these other things are pretty quick. And I think it's important to note, especially if you're in a situation where the athlete's coming off to the sideline, you saw him take a pretty big hit, but they're saying they don't have any symptoms, they're just fine. So that's why it's important to get their symptoms. They're saying, no, I don't have any. Let's do a cranial nerve exam, let's make sure. Let's do MBES on the sideline. And I like to do a modified VOMS. That we don't even see the VOMS on the SCAT at all. That doesn't come about until the SCOT 6, which is really your follow-up documentation. So what can we do practically? Now, I made this up as a flyer just as sort of like a little bit of a guideline, because what tends to happen is if you have an athlete that's comes off the field or the court, they're telling you they have no symptoms. We want to get those, like I just said. You're going to do the first part of the SCAT, so steps 1 through 5. If that all clears, we should be doing cranial nerve assessment as well. And then, what I like to call the modified VOMS. And so I'm not, I want to make sure I'm asking them symptoms first, but they've said no already. I want to make them do some things to maybe elicit some symptoms. And it's hard for them to fake if they're dizzy after they do some of this. So a couple things you can do on the sideline is just have them stand, look at their thumb, shake their head as quickly as they can, back and forth, and then up and down. The other one you want to do is you want to make sure you're having them face the stands or the field, because you want some background activity going on when you do the motor part. They're going to stare at their thumb, and then you're going to have them quickly move side to side and see how they do. And then ask them, do you have any symptoms now? And a lot of times you can kind of see it on their face as well. Let's say they pass that. That's all good. They're still saying no symptoms. We do MBES. MBES looks good. Next, we want to do exertional testing on the sideline, which you guys would normally do for, other injuries, for knee and ankle and such. So this way, you have documented that you have done all of these things as your decision-making process to let this athlete go back to practice or go back to the game. And Dr. Podell has, this is so important because Dr. Podell has served as an expert witness on some legal cases for concussion. And I always talk about this when I'm doing my talks. And, he said 95% of the time, it boiled down to little to no documentation of the injury, or they didn't do enough. Maybe they just asked them how they felt, which, I would like to think people have gotten away from that. But if you don't write it down and you don't document it, it didn't happen, okay? So really important, especially on those kids where you're, trying to decide if they're going to go back in because they're telling you no symptoms. The SCAT is really only good for the first 72 hours, 5 to 7 days, but this is what you would use acutely. And here I'm talking about the second part of the SCAT that I alluded to earlier. This is the part you're going to do in a distraction-free environment, which, halftime, not ideal. So more than likely, this part is not going to happen until after practice or after the game, or in some cases, maybe even the next day. And I know you're probably like, well, why am I bothering with this, Deidre? I already know they have a concussion. We already did the first part of the SCAT. We've got the symptoms. But again, it goes back to documentation. And, we can't always control where our kids go, where they're seen. And unfortunately, maybe they might be seeing someone who's not as experienced in concussion. So it's important for you to have that information and to document it yourself. So on here we have the word list, and we're just going to pick one of them, okay? Now, they did increase the words to 10 words, and you want to use a stopwatch when you're doing this. So I usually use my phone because it's really important that you are delivering the list 3 times at the same speed, okay? So what I would recommend too is, who has the list memorized? So it would be ideal if you could maybe turn on your phone recorder and then write them down later, because chances are they're not going to say them back in the same order, or they'll probably even throw in some words that you didn't say, and that's good to document as well. So we're going to read that list 3 times. So even if they said all the words the first time, second time, we still have to do that list 3 times, okay? Because that's part of the learning part of the test, and we're not going to tell them that we're going to do it later after the tandem gait. Next, we have digits backwards, and again, you want to use a timer to time yourself. I usually set my timer for 5 minutes, so I don't know, it's not going to take that long, but I like to look out of the corner of my eye to watch it tick down, because again, you want to be consistent on the delivery of this. You don't want to be too fast or too slow. So part of my job is I work with Dr. Podell. He's a neuropsychologist, and I do cognitive testing for him. And we also have neuropsychology students that come in and train with us. And this is one of the things we work with them on, because a lot of times for the word lists that we do and digits, they're either too fast or too slow. And I usually talk pretty fast. And so even I've been doing this, almost 15 years, and I still use a timer to pace myself. And so also, I know you guys are probably like, wow, that's a lot of words compared to the SCAT-5. Our kids can't remember that. I assure you they can, because we actually have a test that's 16 words that we give to kids. And so it can be done. So once again, sorry, back to digits backwards. I'm like a squirrel at a rave, kind of get off topic. But you want to just be consistent when you're reading those digits. So it should be 1 second per digit. Again, we're just going to pick one of the lists and read them the instructions. Now, there is a score of 4, and so you're going to keep going until they get 2 lines incorrect. So for instance, for list A, I would say 4, 9, 3. If they got that right, I don't have to read the 6 to 9. I'm going to drop down to 3, 8, 1, 4. If they got that right, I'm going to keep going. 6, 2, 9, 7, 1. If they got that wrong, I'm going to give them another chance and read that 1, 5, 2, 8, 6. If they got that wrong, I'm going to circle no and discontinue the test. So you don't have to read all of those strings of numbers. The other thing they did with the SCAT-6 is they added a time component to months backwards. And I have had an athletic trainer, call me, and she's like, I don't know what to do. I had this kid, he didn't even know the months. And I was like, well, that's a challenge. Maybe try days of the week. But the important thing is, you're just noting that. So sadly, that kid was in junior high. Then I had to go home and test my kid and make sure she could do it. So, MBES, I know y'all know with that. And again, we like to do this with the shoes off. Even on the sideline, I like to do this with the shoes off. Then we have time tandem gait. So this is going to be athletic tape, 1.5 inches, about 10 feet. And we're going to do this 3 times. We're going to have them walk as quickly as they can, heel to toe, down and back. And we're going to do that 3 times to get our fastest trial, an average. Then we have dual task gait. Now this is optional because anything on the scat and the scoat that's in orange is optional, but I would really advocate for doing this because what are we asking our athletes to do? We're asking them to do physical activity while they're having to think about their play, about what's coming up next. And so, you know, tandem gait could be pretty easy for them, so you could do dual task. And it is backwards by 7s, and this is usually where I get the eye roll from everyone, like, I don't think our kids can do backwards by 7, but you could do by 3, backwards by 3. There's also other things you can do, like for the complex task, which I'll show you later for Scout 6, but you are going to do this 3 times as well. So follow-up evaluation is really important. So obviously we're not using the SCAT 6 as our standalone to make our decision. I like to think about the SCAT 6 and the SCOAT 6 as our toolbox. And so we have all these tools in the toolbox to help us form our decision. And again, a lot of the time, I know you guys know, you're like, this is clearly a concussion. I'm going to refer them on anyway. Why do I need to do all this? But good for documentation. Now, you should be following up with them. So let's say you did the SCAT for your initial injury. And again, you know, I advocate for this because maybe they're not seeing a physician that is specializing or really up to date on concussion. And so this just has a little more comprehensive history that you can go over with them. Symptom evaluation, it's the same except for the 3 here, sleep disturbance, like are you having trouble staying asleep, things like that, abnormal heart rate, so that maybe we can pick up on some dysautonomia that could be causing the issues that they're having, same for excessive sweating. The word list is exactly the same as the SCAT, so you would just want to pick list B or C or whichever one you didn't do. Same thing for digits backwards, and then months in reverse order timed again. And then I like that they added this part, the orthostatic vital signs, because a lot of times, I shouldn't say a lot of times, we have had several cases with dysautonomia, and a good way to pick this up is by doing their blood pressure. And so you would do it supine and then standing, and also getting their heart rate and then these symptoms that are listed so that we can try to piece out if that's what's causing their issues. Cervical assessment, obviously a lot better than what they have on the SCAT. Neurological exam, cranial nerves, hopefully we already did that as part of our SCAT, just added to it. Other neuro findings as you feel necessary. Same with the balance and time tandem gait. And then this is added as an optional as well. It's the complex tandem. And so they're going to walk 5 steps quickly forward with eyes open, and then 5 steps with eyes closed, and then same thing for backwards. And so if they have 5 or more points, which a point would be, trunk sway, or they stepped off the line, or they had to reach out for support, this can be a good indicator for concussion. The dual task that I was talking about earlier that is on the SCAT 6, this one just has some different things that you could do. So, if you wanted to have them spell words backwards instead of doing the serial 7s, or you could have them do the months backwards while they're trying to, do the tandem gait. Those are some options you can do. Of course, you can use that on the SCAT 6 as well. On that instruction sheet that I was talking about as a separate PDF, if you want to look at the norms, I don't know why they don't have this on the SCAT for single tandem gait, but you can find this on the SCOAT instructions. The other thing that we have, like I told you, they don't do VOMs on the SCAT, and besides the sideline assessment, the quick one, I don't know if it's, necessary, but I would definitely want to do this as a follow-up with them, because this could pop up. And so this is a good indicator also that, they do indeed have concussion. And they did a modified VOMS. And so I don't really know why, but they took out the vertical saccades, the vertical VOR, and convergence. It doesn't take you that much longer. I would just go ahead and do the full VOMS with them. Because the sooner that we can treat these issues, the better their recovery time is going to be, if we can pick up on this early and intervene quickly. Last part is just the management follow-up plan. You have a nice space to document everything. And then, like I said, anything in orange is optional. I did like that they added the anxiety, depression, and sleep screen, because a lot of times, that's affected or exacerbated by concussion. Now, these are really short, so if you ever need a longer version, happy to send you, what we use in clinic, and honestly, you can find them online as well. And then lastly, the graded aerobic exercise tests. They talk about that in the SCOT. So good segue for me here for the Buffalo treadmill and bike test. So in June of 2023, Dr. Letty, who did the original Buffalo test, they did another study. He also has a bike test as well, but they did that study on, the population that really does not have a lot of research, and that's the, 13 to 18 age group. And they found that if you do this prescribed exercise testing with them, they are recovering quicker than without. And I love his quote in here in the second line, where he talks about it's exercise as medicine to treat concussion. So they're gonna have symptoms when we're working them out. It's just we don't want to more than mildly exacerbate them. And we'll talk about that here in a minute. I just talked about that. Oh, it also helps with, they found in the adolescent group that it helps with persisting post-concussion symptoms as well. And they're our most vulnerable group, and that is because their brains are still maturing. So you can go online and find the Buffalo treadmill test form on Dr. Letty's website. I also did one just because I like a little more information. And so, maybe you can find one that works for you. And I'm hoping this video works, because I wanted to show it to you, but we were having some trouble connecting with the internet, so we'll see.
Hi, I'm Barry Willer. I'm a professor at the University of Buffalo, and along with my partner in research, John Letty, we developed the Buffalo Concussion Treadmill Test. We developed it because in the early days when they first came out with return to play guidelines, they were essentially based on individuals achieving exercise tolerance. We wanted a systematic way of evaluating exercise tolerance or intolerance in the case of those with concussion. And we started using the treadmill test for doing that. My purpose today is to show you how the test works, what are the steps and stages and things to look for, and even some of the nuances of the assessment process. Before the patient is tested on the treadmill, they will have been seen by a doctor, both to assess their concussion and assess whether they are able to do the treadmill test. The Buffalo Concussion Treadmill Test was based on the bulky protocol. We've evaluated this treadmill test for safety and reliability, and we've published papers on that. But in order to guarantee safety, the key caution is that no one with concussion should be exercised beyond symptom exacerbation. Initially, the treadmill is set at a speed of 3.2 miles per hour. We increase the speed for someone who is tall or in very good condition and expected to come close to maximum. We adjust the speed down for anyone who's not so tall and for children. Every minute, the treadmill is raised 1 degree, thereby increasing the workload systematically. With each minute, just before we raise the treadmill, we ask the patient to rate their overall symptoms on the visual analog scale and rate their effort on the RPE scale. We also record their average heart rate over the past minute. Before the patient gets on the treadmill, the whole procedure is explained to them. We tell them about the charts that we use. One is the RPE chart that assesses their effort, and the other chart is a visual analog scale that is an overall assessment of their symptoms. They complete this and then at beginning, and then we assess it every minute throughout the treadmill testing.
So as our test progresses, I want you to make sure you're giving me honest answers to how you're feeling. If you feel like you're getting unsteady on the treadmill, that is something to include into how you're feeling with your symptoms. And if you feel like your lungs and your legs are starting to give out a little bit more, that would be more of our perceived exertion scale, okay? All right, in about 5 seconds, we're gonna see how you're feeling. Caitlin, what's our heart rate right now? 90. How do you feel like you are on our FACES scale?
I'm still
Still at a 2, and how hard do you feel like you're looking over here?
still an 8.
You think you could go up another level?
Yep.
All right, here we go.
While the patient is on the treadmill, the primary thing we're looking for is symptom exacerbation. We use the visual analog scale, that FACES scale, to assess that on a regular basis, but we also observe the patient. We're looking for distress. We're looking for how they feel. We're looking at whether they can continue the conversation and so on. It's as much a clinical observation as it is a numeric one. So when somebody gives us their response on the visual analog scale, we're weighing their response against their actual presentation of signs of distress.
So 3 on our FACES scale. Just keep steady go, and now I'm gonna bring the grade down, and then I'm gonna bring the speed down to a 2.2. We're gonna do a 2-minute cool down, okay? How did the drop in grade feel? Did you have any changes in your symptoms? Headache, worse, dizziness, lightheadedness?
I'm just kind of getting used to it a little
Change in the
bit.
balance?
Yeah.
Okay. So we're gonna walk for 2 minutes at this pace, and then we'll be done with the test, and we'll sit down and we'll sort of see how you're feeling, okay?
Sounds good.
We are more conservative when we're testing someone who is acutely injured. That is, we will stop the test sooner just on the basis of how the person looks. If they show distress, we will often stop, even if they don't necessarily move the 3 points on the analog scale as our manual would dictate.
Okay, I'm gonna stop the treadmill, just so you know. Get your balance. And then when you feel comfortable, there's a chair behind you, you can come back and sit down.
When we're trying to determine if somebody is fully recovered, It's not a VO2 max test. We don't exercise them to the 19 or 20 on the RPE scale. We're perfectly happy to stop it at around 17, at most 18. And when the person exhibits signs of distress, not from symptom exacerbation, but just from the exercise itself.
How do you feel on our symptom scale over here now?
I'm getting a tiny bit of a headache.
Tiny bit of a headache. So how would you rate that on my scale?
About a 1.
About a 1. How hard do you feel like you're working over here?
Around a 17 now.
Okay. Do you feel like you could proceed on to the next stage, or do you think we'll be done for today?
I think we could probably call it quits after this one.
So let's just finish off this stage. Caitlin's gonna get a chair behind you, okay? First thing I'm gonna decrease will be the speed, and then I will decrease the grade just based on how fast you're walking, okay?
Yeah.
So here we go. I'm gonna decrease the speed down to 2.0, and I'm gonna hit the grade at the same time.
Okay.
Great job.
One of the big advantages of using the treadmill testing is that if somebody shows exercise intolerance very early on, that is a low heart rate of, let's say, 110 or 120, it tells us that they not only have the physiologic characteristics of someone with a concussion, but they are likely to take much longer to recover. That's very helpful for us in terms of giving someone some guidelines about prognosis.
Thank you so much. Sorry about that, guys. All right. And I know that is a big ask for you in the training room. I know how busy you are. There may only be one of you. It's not like you can assign that to your student athletic trainer because you have to be hands-on with them. I'm just showing you best case scenario, the prescribed treatment. That way we can really tailor their recovery exercise to them. And also, I am also an advocate of this because, so let's say you have a kid that was hurt on Friday and then miraculously on Monday, I mean, they had symptoms Friday, they reported symptoms to you. They come in Monday and they say they're fine. Are they? Let's put them through a pretty intense test and see, because the other reason I like this test is it's not just about the numbers that they're reporting. It's your clinical observation. And that's why I think that it's great if you're able to incorporate this, but I understand the limitations. Also, you may not have a treadmill, but there is also a bike version of this too. And Sean and I were just talking about, this past year, one of our big initiatives that we did was we asked our doctors to refer every concussion to physical therapy because we wanted them seeing our specialists, our PTs that deal with vestibular and ocular motor issues, to see them right off the bat. And so, they kind of laughed at me when I was like, let's get them in same day, like right after the appointments. They're like, that's funny. And in some cases they could, but they are able to get them in with 1 to 2 days. Because like I said, if we can catch this ocular motor and vestibular problems early on, then we can start treatment and help in their recovery and help them feeling better sooner. Now, are all the kids going? No, because, either the parents don't want to take them, maybe it's an insurance issue, maybe, time off work, things like that. But at least we offer it as part of the recovery process. And so if you are able to, advocate for that in clinics near you, but, Sean was telling me about, that could be a challenge because of no PT clinics. So, but there may be some in your area. I also wanted to show you the no equipment Buffalo protocol. And so this would be good for your junior high kids where maybe they don't have a bike or a treadmill, and really you're just going off of their heart rate and a percentage of what they're working on. And again, they're gonna have symptoms when we're working them out. It's just we don't want to more than mildly exacerbate them. And we're doing it on a scale of 0 to 10, and I'm gonna get into that in a minute. Now, if you look on the SCAT and SCOT, there's the section for the return to learn strategy. Now, we've been doing return to learn, but I think that, you know, this is come to light a little bit more that this needs to be done in tandem with the return to sport. And if they're struggling in the classroom, then that is an indicator that they're still struggling from their concussion. And so we need to, you know, make sure that we are tracking this. And so, you know, I'm not saying they have to come to the athletic training room to do this. Like, you could work out a way where you got a Google form, or they could text you or whatever. But we want to see how they're doing before school starts on that scale of 0 to 10. And then when they come, you know, again, I'm giving you ideal situation here. I know everybody's athletic period is not at the end of the day. Yours may be in the middle. But we want to see how they're feeling after school. Did any of those classes exacerbate their symptoms? Okay, I'm giving you, you know, best case scenario. If your athletic periods at the end of the day, you're kind of killing two birds with one stone, because you're seeing how they did after school all day, and then you have your symptoms before they start exercise, because we have to get their symptoms before they start exercise. And the reason, you know, we see the 0 to 10 on the symptom scale, where previously we've been going by 0 to 6, is Dr. Letty actually led this systematic review on this part of the SCAT and SCOT. So return to sport, same thing. We're going by 0 to 10. Now, if you remember on the SCAT, what's the symptom scale on that? 0 to 6. And so I think that was really done because everything had been that way previously. And then Dr. Letty's research is on 0 to 10. We actually switched as a system to do 0 to 10, because it really doesn't make any sense to do 0 to 6 on the SCAT, and then we're tracking them 0 to 10, which is really going to be a few days later. And so make sure too that if you're looking at this return to sport, that each step is a day. So 2A is 1 day, 2B is 1 day. And I already talked about, you know, they really need to be fully released from return to learn before we can do unrestricted back to sport. And if you compare the no exercise equipment to the exercise strategy from the SCAT, it's really the same thing. Okay, we're going by maximum heart rate at a percentage. And so, like I was just saying, you know, why the two scales? And it's, you know, all the research previously was done 0 to 6 for symptoms, and Dr. Letty's was done 0 to 10 for all his research, so they couldn't really change it, I guess. But like I said, to us, it just makes more sense to do 0 to 10 from the beginning to the end. And I really couldn't find any reason why that is, but that's my thought on that. So up here, I threw just what we do compared to the SCAT 6. We were really already doing this before SCAT 6 came out, but what I wanted to show you was the duration, because there's no duration recommendation on the SCAT 6. So this is, you know, kind of what we have come up with as part of our return to sport. Now, let's talk about the 0 to 10. You know, when you're doing this, the visual analog scale and the Buffalo treadmill and their symptom report, you're doing it on 0 to 10, and I thought we really weren't supposed to ask them how they feel. Remember that for so long? We're like, you know, go by the symptoms specifically, but now we are asking them, how are you feeling overall, like right now, as you come into the training room, 0 to 10? So we added that to our form. How do you feel overall? That's the first thing we're going to ask them, because that's what we're going by to be able to progress them through the return to sport steps. We did a return to learn form and a return to sport form, and maybe you have one, maybe you combined them, but this is what we have right now. The other thing I think that it's really helpful, and I have some if you want to pick them up at lunch, but I have a laminated copy of the visual analog scale, because we found it's really helpful, instead of just saying, how do you feel 0 to 10, to show them the visual analog scale. It kind of helps them kind of determine how they are feeling on their symptoms versus just that huge range of 0 to 10. All right, so they have to have at least 2 days of relative rest. And what does that mean? It means they can be on the computer, they can be on their phone. We don't have to shut them down from any of that, because that's their normal. And so we want them to have their regular activity, just nothing that really exacerbates it. So if they get a headache after watching TV or being on their phone for 15 minutes, then next time just do it for 10. And before we can get them exercising, they have to have that overall, not per symptom, but overall symptom report of 7 or less. Again, they're going to have symptoms while we're exercising them. Make sure you're getting them before and after they're done exercising, because remember, we don't want to go any higher than 2 points on that scale. And this is going to take some time. This is a symptom driven protocol. This is not per day like we used to do. And so we came up with this flyer as well, just to kind of help out, especially with the schools that don't have athletic trainers, just to give, the coaches an idea of what the timeline's going to be. So I just broke it down for you a little bit. So concussion occurs days 1 and 2. They're going to have at least 48 hours of rest, of relative rest. They may take longer, okay? That's why we're tracking their symptoms. Day 3, so you can really get them going exercise-wise on day 3 post-concussion if they meet the criteria. So 7 or lower, you can start with step 1. And what is that? It's 50 to 60% of their max heart rate. So you can tell them, hey, walk pretty fast to class, and that would probably get them up there, because we're not having them not do anything. And while they're maybe waiting for a doctor's appointment, they can be doing this light exercise. Before they go to step 2, they really need to see an MD or a DO so that they continue on with the return to sport steps. And when you think of return to sport, I want you to think about steps 1 through 3 as exercise as treatment. And so steps 1 through 3 are going to last several days to maybe even weeks before they are symptom-free. They have to be symptom-free before they start step 4. So remember, this is a symptom-dictated process, and they have to be symptom-free both cognitively and with physical activity. Of course, we have the concussion recognition tool that I mentioned in the beginning. Pretty basic, but good for your junior high coaches or your coaches that may be on the road. I know everybody has their version of a physician form. We came up with this, and I know it's really hard to read, but if you would like it, I'm happy to email it. But we came up with this on feedback from our athletic trainers, because again, while we try to get the kids into our concussion specialist doctors, it doesn't always happen because of insurance or whatever. But this way, whoever gets this form can see what was done, and we clearly explain that we're going to do exercise as treatment. And that we're getting started on that, and that's part of our concussion oversight team protocol. Also, we have our return to sport protocol documentation form. We really highlighted there that symptoms must be resolved before they start step 4. They're using this form in tandem with the return to learn and return to sport symptoms. So again, I'm not saying that we don't ask symptoms, But in order to progress them through the steps, you have to go by how do you feel overall. So let's say a kid comes in and they say, I'm feeling like a 5 today, okay? Well, what's making you feel like a 5? Now, the first couple times I see them, I'm going to go through the whole list of symptoms because they may not realize some of these symptoms are concussion. But after we've gone through this a few times, then you can just kind of have that conversation with them, like what's making you feel like that today. So it is important to document the symptoms, but remember, I'm not asking you to total the symptoms score. We need to know how they feel overall. So like I had somebody call me the other day, they're like, they had a total symptom score of 20, but they said they feel like, a 6 after exercise, and they didn't move up, and I'm like, then that's okay to go ahead and progress them to the next step. Okay, so we're going by overall symptoms. One thing I like to point out too is we've had this come up, and this is what we use to classify contact sports, because there was some argument at one time about, well, why baseball, why high jump or pole vault, and this is why. It's limited, but there is a chance of contact, and so if you ever need that as your backup, then you have this to refer back to. Something else I always like to talk about that still comes up is, can a physician assistant or nurse practitioner clear an athlete? And the answer is no. Per the state law, it has to be an MD or DO. And then this also still comes up. The note says no concussion. What do? Doesn't matter. They still have to go through your school district's return to sport protocol, and that's why the law was put into place, so that these kids weren't getting released too soon. Because like I said, maybe they're not seeing somebody who is really up to date on concussion. And so it's really important that, your school is aware of this and aware of your protocol, so that if you ever have to go toe-to-toe with a parent sometime, everyone's on the same page. We do have free concussion education. This is more geared to the coaches, and so this helps with meet that 2-hour requirement. We are still in the process of updating it, so I'm hoping by the beginning of the school year in July, August, that we will have this. Right now it talks about the SCAT 5 on there, but we'll have that updated soon. And then, like Sean was saying, we do have the Houston Texans telemedicine grant, and this is sort of a special circumstance situation. So we've had some cases come up where, out in one of the rural schools, they said, the doctor said they won't see them and that they needed to see a neurologist. Highly doubtful. Most of the time, concussion patients do not need to see a neurologist. Unless they have some extenuating circumstances, like they previously were struggling from migraines or something like that. And so that's why we're able to do this. And basically, we connect with you via video visit, and you help us with the evaluation. So that's how we get that done. And then if you want any information, you want me to email anything, I also have, this is to my contact info, and so I have a couple websites. So like that Buffalo treadmill test is on there. I also linked to Duke University. If you need a VOMS refresher, that's a good one on there. They're actually using it for rehab in that video, because they're doing it by seconds when they're doing it, and actually when you're doing the VOMS testing, it's by repetition. But if you're having any problem with that, then there is my info. Always happy to talk to you, share anything that we have, and I really appreciate your time. Thank you.